TopMedTalk.
Well, hello and welcome to the TopMedTalk Zone. We are live from EBPOM Day 2. Monty's going to be joining us here in just a little bit, but it's my pleasure to introduce Professor Saul Aronson, who is joining us from Chicago, right, Saul?
Yes, virtually through Durham.
We also have Henry Howe, who's joining us from the TopMedTalk studios in London, England. He is now a doctor, in case you haven't heard, for all of the TopMedTalk listeners out there. Congratulations, Henry, and thank you for joining us.
Thank you, Desiree. Thank you. You can see I'm sporting the EBPOM t-shirt, which people might be wearing around the studio around here.
Yeah, fantastic. We'll talk a little bit more about the Pockapalooza here in just a little bit. But I'd like to introduce our very special guest who's joining us from Lausanne, Switzerland. It's Dr. Patrick Schoettker. I hope I pronounced that correctly. Thank you so much. Yeah, thank you so much for joining us. How are you doing?
Well, thank you very much. It's a pleasure to join here from Switzerland.
Tell us a little bit more about yourself.
Well, I'm a professor of anesthesia and emergency medicine here at the University Hospital of Lausanne, the CHUV, which is one of the 5 big university hospitals in the Swiss country. We have about 1,500 beds, and we run all kinds of surgeries, and we got fairly affected with the COVID. As you might know, the state of Vaud was one of the biggest places where COVID hit. We learned a lot, and we still have a lot to learn.
Yeah, well, it's interesting, the international perspective, because, you know, we've heard in some European countries, they've not been hit very hard at all, and others. Can you speak to why that was such a hot spot, or what some of the theories are on that?
As you know, Switzerland is a small country bordered by many different countries, and we're very close. Actually, we're bordering Italy. So as Italy was one of the hubs, they got translated to Switzerland. And then we have this beauty of the Swiss Alps, and the Swiss Alps created a natural barrier to the spread of the disease. So some parts of Switzerland were fairly spared. Some others were hit fairly hard. It's just the wave that we saw coming in. We had time to be prepared, learning from our friends in Italy, in China, in Hong Kong. And some places were totally spared, some others were more affected. And we were one of the most affected.
Mm-hmm. Well, tell us a little bit about your institution in general then. I mean, how were you seeing major surges there? And did you have to have a lot of transition into, ICU, creating more ICU beds and things like that?
Yeah. So normally we run about 35 beds in ICU. And by seeing the wave coming in and trying to understand the timings of the waves, we doubled, first of all, we doubled the capacity of intensive care beds. And then we decided to triple it with an extra possibility to make it 4 times bigger. By doing that, we had to reinvent the hospital, because evidently you need to have walls, like rooms where you can get the people in. We need to have equipment that you need to be able to ventilate or take care of these patients. And I'm only talking about ICU. Yeah. And of course, you need to have human resources, being intensivists, emergency physicians, anesthetists, and even sometimes orthopedists or dermatologists, because not everybody is available all the time. So it was quite a challenge from the technical point of view, from a human point of view, and from general management point of view. And of course, one of the first areas that was used to be transformed into an ICU setting was the operating room. So we closed down half of our operating rooms. We transformed each OR into 2 beds of ICU, using the available human resources like anesthetists, nurse anesthetists, to take care of these patients.
Oh, wow. That's crazy. So what was your surging capacity? I mean, how many patients were you seeing? What was the max patients that you saw there?
So the hospital accepted about the maximum 400 patients, COVID. And out of these 400, we had about 80 to 90 in the ICU. That was the maximum surge we had. The state of Vaud, where the Hospital of Lausanne is located, is a fairly big state, and we organized the centralization of the resources in our university hospital, and we were able to spread or send out the patients, depending on how badly injured or sick they were, to the various other hospitals. But we kept the most serious ones, the ones who were on ECMO, the ones who needed prone ventilation, etc., in our institution.
Yeah. Well, Saul, now I know at Duke. Oh, I'm sorry, you were going to comment.
No. Everybody, is adjusted to this world pandemic in their own unique and challenge-meeting ways. Were you using anesthesia machines as ventilators? And with respect to resource capacity and reserve, how close to the edge did you guys get in terms of, limitation of a scarce resource?
Well, it's a fantastic question because we had to think creatively. Evidently, one operating room, you have one ventilator, one anesthesia machine, but which is actually not designed to work 24 hours a day during 7 days or 10 days. So we had to make some interesting calculation. Hey, how much oxygen do we need for ventilating that patient at that flow rate? Because if you go below the certain amount of flow rate, you get water in the pipes and everything. So we had all these fantastic issues. And then when we were increasing the number of ICU beds, there was a shortage of ventilators. And which is fantastic in Switzerland, we have a Swiss army. And we discovered that the Swiss army had actually...
We use your knives.
Yeah.
And you can almost ventilate the patient with a Swiss army knife, right?
You could definitely do it, Greg.
But the good thing about the Swiss army, we discovered by chance that they had a huge stock of 100 ventilators, high quality ventilators that nobody knows what they would be using them for. So all of a sudden, we were able to connect to the Swiss Army, and they helped us a lot manage this situation because we were able to dispatch the ventilators to the structures that needed them the most. This helped us a lot.
Where are you right now in terms of the surge? Is it ascending? Is it descending? Is it stable? Is it reascending? How would you characterize the world in Switzerland right now?
So we started on March the 13th, which was the beginning of the bad news. The maximum was about 2 or 3 weeks later. And on April 27th, we went out of the critical zone. And now it's interesting, 1st of July, we see the numbers are coming back slowly, but they're coming back. For the last 4 days, we have seen a doubling of the COVID situation. So every day, there's twice more people who have been diagnosed with COVID. It does not relate to an increase in hospitalization, although yet. And what is interesting for us that we had to take special procedures to take care of these patients. Also the ones who were COVID positive and severely sick that had to go to ICU or to operating rooms. But now we see people who get elective operations that turn out to be COVID as well. But the COVID is not the biggest issue, right? It's the issue right here. So we're slowly seeing, it's not a wave, like a little wavelet, coming in and out. I'm just expecting over the next 2, maybe 10 days, 2 weeks, how high the wave will come back. But we're specifically back in something which is new.
Do you think this is a rhetoric question, I have my own opinions. Do you think we're getting bored of being rigorous? Or do you think this is a different strain or a different phenotype? Are we all suffering from attention deficit disorder and just can't stay the course and behave appropriately? Why do you think this isn't a second wave? It's too soon for a second wave. This is a residual of a poorly managed first wave, my opinion.
Well, the Swiss were very robust. When somebody tells you to do it, you do it. But even a Swiss, after months of having the social distance, wearing masks, etc., you get a bit tired of it. And the interesting thing is we see now that the National Council has given us freedom to move not 2 meters away, but 1.5 meters. And this can be, depending on what time of the night, getting a bit shorter and shorter. And now we see these little hubs, these little clusters coming out, people working together or being together in a disco, people being in the bar. So I think what you said is totally right. People are getting tired of living this artificial life, which is very different than the one that you used to live before.
Just real quickly, Henry, can you talk about a little bit about your experience with COVID as where you were a medical student, and were you able to identify with some of the things that Patrick was discussing?
Yeah, so I was a final year medical student at Bristol University, which is a couple of hours from London in the UK. We were supposed to graduate at the end of July, but they decided, obviously, when the pandemic hit that, they graduated us early in April so that we could come and help out. So I did 2 months working on the lower GI surgical team. Fortunately, though, at Southmead Hospital, where I was at, we didn't really have the big surge that was expected. In the southwest in the UK, we're actually quite lucky, and the R value was relatively low. So we never got that hit, as per se, and for me it was actually quite a nice way of being introduced into the job. But certainly in London, it's hit hard here, and there was expansions. Plans were put in place in Southmead for expansions. We have a 90-bed ITU there, the largest ITU in the southwest, and they doubled up ventilators in each room with the anticipation that we were going to be hit hard, but ended up only working at about quarter capacity.
Gotcha. Well, one of the things I'm thinking is, as Patrick, as you were speaking, and I know about Saul, some of the things that you were discussing, and Henry, is that there have been a lot of lessons that we've probably learned from all of our experiences, because they've all been slightly different. Patrick, can you speak to some of the things that you guys have taken away from this first initial, or be it whatever, that Saul was referring to? Maybe it's not our first wave, maybe we're still in the middle of it. But tell us about some of the lessons that we've learned from that. I know that you've had some experience with, frontline providers with intubations and things like that. And we wanted to discuss, video laryngoscopy and some of those points.
So the interesting, we learned a lot, and we're still learning. One of the things we learned is that how do the people get their information? As medical doctors, we're trained to read and listen or understand, and we go through scientific literature. And all of a sudden, we saw a big surge of news coming out from some different threads, being, social media.
Yeah.
Interesting that scientifically trained doctors, they were paying more attention to the noise on these channels than what they were reading in the facts. And this generated a high level of uncomfort and, I would say, unnecessary buzz, that people were getting threatened or frightened that they would get self-infected, and they would be reading some emotions from people in China and Italy and saying, hey, they have a high percentage rate of infected anesthetists, we must pay attention. So it was very interesting that one of my job was to convince people that what we're doing is the right thing. Yeah. And that the picture they were seeing with people wearing Ebola suits was not necessarily the picture taken for the COVID situation, but it might be an out-of-context taken picture. So this was very interesting. And I think once we streamlined the way that we communicated to our teams, everything went down a bit and everything was smooth, and we could concentrate on the medical care of the patients and our personnel, and not managing this, the high impact of emotions, which is evidently running around when you manage such a situation.
Yeah, absolutely. Go ahead, Saul.
Have you modified or reinforced or accentuated any of your protocols with respect to securing an airway, to sort of pivot to the discussion on video laryngoscopy? Had that been standard? Is it now standard? What has COVID done to accentuate and accelerate your behavior?
So there is a conflict of interest, because I'm highly fascinated by the video laryngoscopy, and I think it's a fantastic tool that we should have had over the last 100 years. I reintroduced it in our institution 2006, so it's been now 14 years that we manage it. The interesting thing is that the COVID situation made it very clear that we needed to take precautions for the people who were managing the airway, and that the video laryngoscopy was a fantastic tool that allowed distance from the source of infection, that allowed the sharing of the airway, and that allowed for the best trained practitioner to be in the room with the patient. So this was a fantastic change for somebody like myself, who's a big advocate of the video laryngoscopy. We took the threat away, and now, a month later, nobody's giving any doubts about the usage of such a device anymore. So it made the evidence even more evident. So interesting for us, nice for me, and nice for the patients, of course.
I think it's an interesting point that you just raised, which is there's already been in my opinion, a slow and steady shift, if you will, in behavior and culture for first choice of tool to use to secure an airway. And I think some of the data that we're seeing right now, failure, rescue, and just, ease of use, however we measure that, are pointing more and more to video laryngoscopy being the standard of care as we evolve. Interestingly, what you shared with us is that this crisis of COVID has been a catalyst to accelerate that behavioral change. And we wouldn't have sought it out, certainly not have expected it, but it is nevertheless an interesting consequence of COVID, in that I think we're now more sensitized to the value add proposition of video laryngoscopy. Where do you think we're going to go from here? Does that toothpaste go back in the tube?
What we noticed is the guidelines managing the airway of COVID patients was always telling the airway management should be done by the most experienced provider or practitioner. So now we come to a situation where there is a goal for one tool to be used. And the experience is not only dictated by the numbers of years you've been doing your job, but by the numbers of years you've been using that specific devices, right? And this is a situation which was very interesting to read, because we had younger doctors who had more experience with the video laryngoscopy than more senior doctors who were better with the direct laryngoscopy. So who do you put? Which one is the most experienced?
Great question.
Is it the young one who knows the tool, or is it the older one who knows the trick with the old tool? So we managed it in a Swiss way, saying, hey, we put in the most experienced one, the numbers of years, and the most experienced with. And then we came up with a team of intubators. And it happened to be many, many young, at least 5-6 years of training, right? So it's not a junior one. We do not want to put in threat these patients. And the other interesting thing is that in my institution, it's a teaching institution. What I like the most about the video laryngoscopy, it allows you to share the airway. So for me, it's a teaching tool. But there, in that COVID situation, I was teaching it to myself because there was nobody to watch, because there was only one guy, right? Yeah. So it's you can use the same tool for different things, teaching, but also allowing a physical distance to the airway, allowing the better passage. And then in our institution, the video laryngoscopy, it's not necessarily the first tool we use. It's the first one if it's difficult. But here, this one was the first tool to use. So we had to transform a little bit our difficult airway management. What do you do next if you fail? Yeah. So it was a whole gymnastic to be able to render the best care.
Patrick, very similar experience in the UK from the point of view of recommendation that primary video laryngoscopy first, of which I think was widely accepted. And we were, like we've been discussing, we're making that transition into, is it going to become the new norm very soon anyway? But one of the discussion points there is whether the shape should continue to be like the laryngoscopes we've been familiar with, such that you can help the old to get to the new place easier, perhaps.
I have a strong view that the hyperangulated blade is a fantastic design because it allows you to look at the airway in a more anatomical way. Because if you think back of what does the Macintosh blade, which is a fantastic tool, right? It displaces the anatomy. And I'm a big fan of leaving the anatomy as it is and working around the anatomy. So that's why I'm a big advocate of the hyperangulated blade. If I can have a tool which has the two, even better.
I will say, though, that for a lot of people did talk about, and I just know this from my own personal experience of intubation utilizing that hyperangulated, is that there is a learning curve that goes specifically with that versus just video laryngoscopy, because there's, a lot of different products and things that we've all been exposed to. Fantastic in a well-trained hand, again, like you said, but it's very easy to train up on those things, I feel like, in my own personal experience. Would you say that, Patrick, as well?
Yeah, I like to make the comparison when the surgeons went from the laparotomy to the laparoscopy. I mean, it's a different state of mind. You need to be able to see on a two-dimensional screen a three-dimensional anatomy. You need to be understanding the way the anatomy, the tube will need to go through, because the tube will still need to go through that. And it's not because you have a view that you have success of intubation. So it's a different way of reaching the goal than we have been trained with the direct laryngoscopy. And I think it's a question of generation. We are getting there. And the younger doctors, they all want the video. And once they see the video laryngoscopy with the hyperangulated blade, I think it's one step above, but you need to be able to understand and have the tube go where you need to go.
From your experience, this is a Monty and or Patrick question. How much is enough? At what point have you figured out formulaically when one is competent?
You mean you mean from the transition from what you used to do to what you do now?
Yes.
Well, if it's me and you discussing this, Sol, it's probably the wrong people talking about it.
Well, but let me then, deflect to Patrick, because you are front and center. Obviously, 30, 40 years of experience ain't the criteria, because we're now talking about a new technology with a new application. So what is that criteria that would, to segue this to the COVID discussion, make you feel comfortable that that's our first line airway team because they are competent? What is that threshold in an objective, formal way?
So we have had huge discussions about that. And I don't believe in numbers. I believe in people understanding what they do. I have some residents who, after 10 intubation with the laryngoscopy, have demonstrated total understanding of what they're doing and ways to find solutions where they couldn't get it. I have some others, they have been using it 100 times and they still don't understand what they see. So when everything is fine, that's easy. The problem is that I want to cover the ones that are very difficult, where you have a beautiful view, but you still can't get the tube in. So our solution in our institution, it might be a very Swiss solution, is I have an expert, so usually it's one of my team or myself, and I'm next to the guy, and he needs to demonstrate and explain to me what he's doing, what he's seeing, and how he's going to reach the goal. And so I say, okay, you're good for fit, you're fit to fly, or you still need some more training. And we train on mannequins, but also on the patients that we do have here, right? We have many difficult patients. I'm head of ENT and neuro anesthesia, so we have all these fantastic patients who need to be operated with difficult airway. So we use that for training and validation. So it's not a number, it's a certificate of competency.
Perfect. Well, Henry, I hate to leave you out of the conversation as a junior doctor there. You probably haven't had a chance to intubate a lot of people, but you probably have a perspective on this.
It's actually really interesting listening, Desiree, because, I haven't used a video laryngoscope, but I have once or twice during med school used a normal laryngoscope. And the training aspect, I would definitely, you look down and I'm sort of don't really know what I'm looking at. And it's okay to watch videos afterwards, but someone directing you through it at the time is really helpful, and it definitely would be useful. And I quite like the idea as well, especially in the COVID times, of the separation from the chance of catching anything. So that's really useful. I'm all for technology and advancement, so I quite like that.
That's a good perspective. I can say from the front lines myself that I can relate to everything that you've been talking about, Patrick, because as a frontline person who is intubating, someone on a daily basis, it's hard enough as it is, but you put COVID into the mix. And even though it's not necessarily different than your TB patients or other high risk patients that you're intubating, it just has taken on a whole new level. So anything that can help you feel a little bit more comfortable in that situation. And I do love the idea, and it's going back to the difficult airway scenarios where you're working together as a team to get somebody intubated. And when it's crucial like this, and, I've talked to a lot of people about you have to take your time as you're getting dressed in PPE. And if you're, having to intubate emergently on an intubation team, or even if you're in the OR, everything's just slowed down so much more. And the idea of having that team together and everybody's focused in on one another and focused in on the patient, it's been really, really good, actually, for us in the experience. And it's taken on a whole new level of that teaching aspect. So even those of us, like you said, who've been doing it for a very long time and feel very comfortable with a blade in our hand, it's still like a whole new perspective. And so I think, Saul asked you before where you see this heading. As far as you guys in Switzerland and maybe a world view on this, when it comes to video laryngoscopy, this new change, I think it's been very, very positive.
I've got a question. So it sounds very much so like you have two pathways in the training. You either go down with the video or you go the opposite way. What is the planning? Is there a sort of a happy medium in which both techniques are part of training pathways, or do we just go down video in the future?
I think there is somehow old-fashioned dichotomy between video and direct. I think the dichotomy is Macintosh blade versus hyperangulated. Mm-hmm. That's the thing. Because if you go Macintosh, you can go direct. That is, you can have a look through the mouse, or you can look on your screen if you have a video. If you have hyperangulated, you only have to look at the screen. So I think the dichotomy is more this way. Old-fashioned is direct, Macintosh direct versus video. And I think that's the wrong way of thinking. In the future, I think the video, the availability to share the airway on screen will be much, much, much more available because everything is optics and becoming smaller. The more question is what kind of blade, and that's it. The interesting thing that we had the discussions in my department, because when you bring in new devices, even after 14 years, you still have people who believe in the other one they've been using 10 years. There is an old, I would say, there is still a myth saying that intubation with hyperangulated blade takes longer than with the direct Macintosh. And the COVID situation is interesting because we know that we need to go fast to intubate them because evidently they have a lack of oxygen reservation of reserves. So we need to go fast. So sometimes we're taking a tool that has been designed for a higher success rate, but it might take a bit longer towards another one that is maybe faster, but not the best one. So we had some good discussions. But finally, we all agreed that the video was the best device, and we're very happy to use it. And now all the goods are good.
Henry, I would presume to say it's probable for your generation to need to know both. It's not instead of, but it's probably in addition to.
But my hunch, Henry, is that very soon, probably in the wake of COVID-19, because people are going to be reluctant to put their head in the mouth of the patient, that you'll probably learn video laryngoscopy primarily, and you'll be taught how to do it non-video laryngoscopy as a default mode if the electricity fails, for example. Whereas we've learnt it the other way round. In a bit like, myself and Sol had to learn to do things like spontaneously breathing someone down in the left lateral position and blind nasal intubation because if in case the laryngoscope didn't work. So we've stopped that now, I think. But so I think the difference will be you'll learn probably VL first, probably.
Do you think it's kind of like the ultrasound? I feel like this is a lot like the ultrasound conversation. Sol, you've been a huge proponent in kind of diving into technology and things like that. What do you think?
Well, I think, philosophically, just to wax and wane, technology makes us smarter and it lowers the barrier to getting smarter. And that's a good thing. It levels the field so that a broader, larger component of that base can be experts. And I think that's what technology does.
I think technology is the way to go. It's here. So why don't we use it? And what we have designed, for example, is teleintubation. So there is a junior intubates using a smartphone just as a screen because it's always there, right? And then we use a friend of ours, the expert, who's maybe next door or the other hospital or at home, looking at it, and he can give some advices. And you use the smartphone because you're able to call, you're able to view, and you're able to discuss. So this opens a new door. This could very well be used during the COVID, but also through all various systems, being paramedics, doctors, etc., etc. So you can expand and the common thing is technology.
I was just laughing. Sorry to go back over the decades. Is the tele support for laryngoscopy used to be you'd get a call at 2:00 in the morning, and you're 10 miles away asleep, and they'd say, "I'm struggling to intubate the patient." You'd say, "Try harder," because that was about the best you could do.
No, it's interesting. I guess you technically could pick up your smartphone and take a look at the airway.
Absolutely.
While you're a junior doctor, someone else, a respiratory therapist, whoever. This is a good question for you, Patrick. Have you, as far as like intubation teams, I know here in the U.S., respiratory therapists and there are other providers that may be intubating patients. Does that ever happen in Switzerland, or what is your experience with that?
In Switzerland, the intubation is a job which is done by a medical doctor, mostly anesthesia. It can be done by any kind of doctor who's trained. which doctors are trained, anesthetists, evidently the intensive care specialists, sometimes the emergency physicians. But when it comes to a difficult intubation, we try to put on frontline the ones who see them the most, which are still the anesthetists.
Are those who are more novice or less experienced, are they putting video laryngoscopy into those people's hands? And this is not necessarily in COVID because you want the most experience, but if you have, intensivists that may be only intubating at 2:00 in the morning when anesthesia is not available, are they going straight to video laryngoscopy now?
They're trained in our institution, they're trained in our department, and we provide their airway equipment. So we decide what's the best airway equipment, and then we give them the possibility to train, because you need to be aware of what's going on and what equipment you have. So we train them and we follow up on their, and at the beginning when we introduced that in our ICU, there was always a trained anesthetist next to the ICU. So we work as a team.
Yeah. So what is your experience with that? Because I know for us here in the US, we do have other, again, not necessarily during COVID, but we have other types of providers and other people that may be intubating. And for us, we've put video laryngoscopy into those people's hands. Have you experienced that at Duke as well?
Nobody owns the right to use any technology. So those that are deemed, certified and credentialed rather to perform a procedure are deemed credentialed to perform a procedure, and we wouldn't, inhibit them to use any technologies to enable them to fulfill that. It's generally still a procedure that is in the domain of anesthesiology. Our ED docs obviously are also skilled and credentialed to intubate. I think the same, answer that Patrick just shared would be the one that I would give, that obviously if it's easy, anybody can do it, but often it isn't easy, and often you don't know when it isn't going to be easy. So therein lies the conundrum. As we were just having this conversation, I was just sort of thinking that for a long time, for lack of a better word, I'll say the ownership of the domain of airway management has been under the auspices of anesthesiology and experts for airway management. And I support that. But as technology advances and makes, if you will, that which heretofore has been challenging and difficult and not easy to predict when it's difficult and challenging, I think it's going to change the paradigm. And I think we have to be prepared for that reality. It was fascinating for me to hear that those of us with decades of experience of airway management are now going to have to sit in the back of the bus because we are no longer the ones who are most competent to utilize these new tools. And so, the first ones now will later be last. And it may be that as these new tools are developed, there's a whole new generation and a whole new, if you will, definition of that generation that becomes the expert. So it's something to just sort of heed in a, again, philosophic kind of espousal way.
Well, Patrick, wrapping up here, because I think we've been going almost 30 minutes now. Can you share with us, it sounds like you guys have done amazing things there to create this team using video laryngoscopy on your COVID intubation teams. Talk to us about how you got buy-in and how you got everyone to support that. Because just as Saul said, I'm sure there were a lot of people that were feeling like, whoa, I've intubated, thousands of patients in my career. I should be able to do this. What was buy-in like to try and get that going in your facility?
You mean about the video laryngoscopy?
Yeah.
Related to COVID?
Yeah, and just, who's intubating who and when and all of those things.
There was much emotions around COVID, right? Everybody was getting afraid that he was going to be infected. So the people who are like airway freaks, they had probably understood it way better, and they knew that they were very comfortable using a device. So they knew they were getting the risk lower than the other ones who were not comfortable with the device. So it was very easy actually to convince people to, hey, let's do it. We are the guys who manage the airway. We'll do it in that specific situation, and then we'll do the snowball effect and train the others and see. This was nice. The interesting thing is that, and Saul talked about the age. I'm old.
Oh, no.
I mean, once you've been in the business for 20 years, you're old. Yeah. I mean, everybody thinks you're old, right? But sometimes when the older is called in because the youngers can do it, all of a sudden you become very young again, right? You're their best friends. So I think it's all a question of success and how you bring the message across and what's the goal. And always keeping in mind what we're doing. We put the patient in the middle. These are the needs of the patients. And we always put the best team around. If COVID would be a situation where we would need the best anesthetist who does local anesthetics, I would be the worst one because I never do it in ENT and neuro anesthesia, right? It happens that we need to manage the airway because this was one of the area that was affected by the disease. So evidently the ones who had this expertise in the airway were called up front. The next disease might be a different one. And it's all a question about putting the patient in the middle, I would say.
Yeah, that's a great point. Well, to end on that, I just want to say thank you so much for joining us on this great conversation about video laryngoscopy at the times of COVID. I hopefully we'll be able to revisit this in a year's time when COVID hopefully is going to be stemmed. The tide will be stemmed. We will still be talking about utilization of video laryngoscopy in practice because, as we stated before, I think it's an important move for all of us. Good luck in everything that you're doing. Keep doing it the Swiss way because you guys are doing good things there.
Okay.
Cheers, everyone. Thank you.
Cheers.
Take care.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.